Good afternoon, everybody. My name is Dr. Aditi-Saraf. I'm from Pune Mangeshkar Hospital. My topic for today is imaging findings using a combined MRI and CT protocol to identify the entire iceberg in post COVID 19 mucormycosis, presenting clinically as only the tip. The coronavirus disease infection was declared a pandemic by the World Health Organization on 11th March 2020. It has been a global health concern with wide range of disease presentation ranging from mild to life-threatening infection. While most of the patients fully recover after COVID-19 infection, those with underlying immunocompromised state may suffer from secondary bacterial or fungal infections. Invasive rhinoorbital mucormycosis is a rare invasive infection caused by fungi of class Phycomycetes. We observed increased frequency of the disease in patients who have had a recent COVID 19 infection. Infection starts in the sinonasal mucosa and rapidly spreads to the orbit and brain. It appears to be a result of multifactorial conditions like diabetes, immunocompromised patients after extensive use of steroids, and systemic immune alterations caused by COVID 19 infection itself, which may lead to these secondary fungal infections. It is a very serious, rapidly progressive condition which can be fatal if not diagnosed early. A combination of contrast enhanced MRI, which provides its excellent soft tissue resolution, and a CT scan for its bony component, helps in delineation of involvement of important structures. Early and accurate diagnosis of infection and its extent is important in effective surgical as well as medical management, early detection of complications, and can help prevent a possibly fatal outcome. The medical treatment includes administration of systemic antifungal drugs such as amphotericin B. The surgical treatment includes debridement of the affected tissues with functional endoscopic sinus surgery, that is FES, which is useful for patients in early stages of disease when the disease is confined only to the sinuses. Open surgery and exenteration of orbit is performed in cases of intraorbital extension or intracranial involvement as well as skull base involvement. These patients usually present with facial or paranasal sinus related pain, nasal congestion, serosanguinous nasal discharge, maxillofacial soft tissue swelling, fever, and epistaxis. Neurological symptoms in case of intracranial extension include headache and confusion. The orbital symptoms include visual disturbances, sometimes even loss of vision, proptosis, and ophthalmoplegia. The diagnosis is usually made by nasoendoscopic biopsy of the involved areas and histopathological visualization of fungal invasion. Culture or KOH or calcophos staining of the soft tissue obtained by nasoendoscopy also aids in diagnosis. First, we will discuss about the non-invasive form of mucormycosis. As the name suggests, the disease is confined only to the sinuses. The sinus involvement is seen as heterogeneously enhancing mucosal thickening on post-contrast images with T2 dark elements within. These T2 dark elements represent fungal hyphae. MRI is extremely sensitive in demonstrating these fungal elements, thus helping in early diagnosis of mucormycosis. This is uh, a coronal T2 weighted image showing heterogeneous mucosal thickening involving bilateral maxillary sinuses as well as left ethmoid sinus and the left nasal cavity. These black T2 elements are seen within these sinuses. These are likely to represent fungal hyphae. MRI is very specific in diagnosing these fungal hyphae. We do CT scan for bony component in all the patients undergoing MRI for suspected mucormycosis. CT usually shows bony erosions and destructions as well as thinning of the sinus walls as well as cribriform plate and skull base. The first image is the CT coronal image showing thinning of the nasal turbinates as well as erosions In the heart palate, we also see few air foci in the heart palate due to fungi. The second image is of CT axial image showing erosion and destruction of all the walls of right maxillary sinus as well as the pterygoid plates which are normal on the left side. The disease can progress to invasive form in a very short period of time, extending beyond the walls of sinuses. The orbital involvement is very common. When the invasive form of the disease has a very high mortality of approximately 49.7%. This is the coronal T2 and the coronal post-contrast images showing extension of the disease into the right orbit from the right maxillary as well as right ethmoid sinuses. We see a protruding soft tissue within the orbit. Uh, Inflammatory changes within the orbit, suggestive of orbital cellulitis, are seen in the form of intraorbital fat stranding as well as bulky and enhancing extraocular muscles. If we compare to the opposite side, the extraocular muscles are of normal caliber, whereas these muscles are thickened on the right side. The disease can spread along the optic nerve sheath as well from the orbital apex or from the ethmoid sinuses. This is the post-contrast T1 axial image showing enhancement of the optic nerve sheath. We also see some orbital fat stranding and proptosis on the left side. We also see some left ethmoid sinusitis and a soft tissue at the orbital apex. The involvement of optic nerve itself is not a very common finding. It can be seen as a nerve infarct. These are the diffusion weighted images showing restricted diffusion within the left optic nerve, suggestive of optic nerve infarct, possibly secondary to retinal artery occlusion by the fungi itself. Mucormycosis can spread to adjacent soft tissues like premaxillary soft tissues, retroantral space, pterygopalatine foci, masticator spaces due to direct extension of infection from the maxillary sinus. Image A shows heterogeneously enhancing mucosal thickening involving bilateral maxillary as well as posterior ethmoid and left half of sphenoid sinuses. We see extension of soft tissues in the retroantral space. We also see extension of soft tissues along the pterygomaxillary fissures and pterygopalatine foci. We'll talk about perineural spread of the disease. Usually, this term is confined to head and neck malignancies which spread across the uh, facial nerves. However, fungal hyphae tend to involve nerves and vessel walls, leading to perineural spread of the disease. Spread can occur along the branches of trigeminal nerve, most common being spread along the infraorbital nerve, usually in patients with orbital disease. Fungal sinusitis involving roof of maxillary sinus can lead to fungal invasion of the inferior orbital fissure. Further, the spread can occur to the pterygopalatine fossa, foramen rotundum, and up to the cavernous sinus. These are the post-contrast coronal and sagittal images showing fungal sinusitis involving the right maxillary sinus roof with involvement of the right infraorbital nerve. This is the nerve seen in its entire extent, which appears thickened and heterogeneous. The second common route of spread is along the interpterygoid portion of mandibular nerve across the foramen ovale. This occurs due to extension of the soft disease into the masticator spaces or pterygoid muscles. The spread of the disease along this nerve can lead to contiguous involvement of cavernous sinuses as well. The first image shows bilaterally thickened uh, mandibular nerves across the foramen ovale. The second image shows the left-sided thickened mandibular nerve with heterogeneous enhancement. This enhancement is reaching up to the left lateral wall of cavernous sinus. On the right side, we do not see any nerve enhancing or there is no bulkiness of the right sinus, right cavernous sinus. However, the left lateral wall appears bulky, suggestive of spread along the cavernous sinus. Perineural spread of the infection can also occur rarely along the superior orbital nerve. It's a very rare finding. We have hardly seen 2 to 3 cases of spread along the superior orbital nerve. As seen, there is no thickened nerve on right side, but we see it on the left side. Olfactory bulb involvement is also not a very common feature of mucormycosis. We have seen in couple of cases. It is seen as bulky olfactory bulbs and results due to involvement of the cribriform plate. This can cause anosmia in these patients. This is the coronal image showing bilateral bulky olfactory nerves showing heterogeneous enhancement. Contiguous spread of the infection is seen in the left basifrontal lobe as well. Cavernous sinus involvement is pretty common. Further progression is seen as direct extension of the cavernous sinus either from the ethmoid sinuses or from the orbit. These are the post-contrast T1 weighted image and a T2 weighted image showing features of orbital cellulitis as orbital fat stranding. A soft tissue at left orbital apex. We do not see anything on the right side. This is the enhancing soft tissue at the left orbital apex extending to the left lateral wall of cavernous sinus which appears bulky. This is a case of bilateral cavernous sinus involvement where we see orbital enhancing soft tissue at both orbital apices as well as enhancing mucosal thickening involving the bilateral posterior ethmoid as well as sphenoid sinuses with extension along bilateral lateral walls of the cavernous sinuses which appear bulky. Involvement of the internal carotid artery. There can be partial encasement of cavernous portion of ICA due to the enhancing fungal sinusitis with or without thrombosis. This is the axial T2 weighted and this is the coronal T2 weighted image showing mural thickening of the cavernous portion of ICA. However, a normal flow void is maintained. As on the left side, we can see this is the ICA. There is no narrowing of the ICA and the black in between is the flow void which is maintained. On the right side, it is lost, suggestive of encasement of the ICA. Complete occlusion of the cavernous segment of ICA due to encasement by fungal infection can also lead to thrombosis and brain infarcts. This is a case of left cavernous sinus ICA thrombosis showing loss of flow void within the ICA. On MRI angiogram, we do not see the left internal carotid artery suggestive of thrombosis. There is a resultant infarct on diffusion weighted imaging in the left periventricular region. Contiguous spread of the disease intracranially can lead to formation of extradural abscess. This was a case of post-exenteration of the orbit. There was a recurrence of the disease within the orbit with formation of a large fungal abscess, which was extending up to the anterior temporal dura, forming a large extradural peripherally enhancing abscess. Adjacent dural enhancement along basifrontal or temporal lobes is common. In some cases, it is early indicator of the intracranial extension. However, most of the cases, it is purely reactive. This is the flare post-contrast image showing thickened left frontal dura. As the infection progresses intracranially, it can lead to cerebritis and further cerebral abscess formation. This is the coronal T2 weighted image of the brain showing an ill-defined T2 hyperintensity within the right frontal lobe likely to be secondary to cerebritis. Another example showing a large intracerebral abscess formation. This is the eggshell flare and post-contrast T1 images and the coronal images showing a large abscess within the right frontal lobe. Skull base osteomyelitis is also common in case of extensive fungal sinusitis. It presents as erosions and destruction of the skull base, the maxillary alveolar arches, or the hard palate. This is the CT scan showing destruction and erosion involving the basisphenoid, the greater wings of the sphenoid bone, the petrous portions of the sphenoid, as well as bilateral maxillary sinuses. This is seen on MR as heterogeneous marrow involvement within these bones. MRI helps in or early changes of skull base osteomyelitis because of the marrow changes are appreciated better on MRI even before there is erosion or destruction which has been set up. Now, what is the role of imaging in follow-up scans? A combined CTMR study helps in differentiation between residual versus post-operative changes. Use of T1 and T2 weighted images along with post-contrast study helps in differentiation of post-operative necrotic tissue and multiple areas of hemorrhages versus the residual fungal elements. Disease progression or regression as well as post-operative complications can be seen after comparing pre-operative and the post-operative imaging studies. This is a case of follow-up of fungal sinusitis involving the left maxillary sinus, seen as heterogeneously enhancing thickening involving the left maxillary sinus. After 3 months of amphotericin B given intravenously, the disease had completely resolved. The second is a case of residual disease as well as the disease increased. First, it was involving only the anterior and the medial walls of the left maxillary sinuses. After 3 to 4 months of follow up, the disease involved both the maxillary sinuses as well as there was enhancing soft tissue in the retroantral space, suggestive of disease progression. So, what are the take home messages? Developing mucormycosis in the post COVID 19 setting is like going from frying pan to fire for the patient and his family in this rough patch of pandemic. With our experience, we suggest that it is of paramount importance not to delay and misdiagnose mucormycosis. This can save life of a patient and reduce associated invasive treatments, as already these patients are usually immunocompromised on some anti-cancer drugs. They are usually diabetic patients, so it becomes difficult for them to handle fungal sinusitis. With high sensitivity of MRI and characteristic imaging patterns found in mucormycosis, it is the most important tool for early diagnosis. Combined use of CT and MRI is extremely helpful for diagnosing and follow up after surgery as well. Thank you so much.